And well, the silver anniversary is also something to celebrate with the summer school, so congratulations on that. So what I was going to do in my remarks tonight was first reflect a little on the dramatic events of the past year, and on then substantively the work of the independent panel on pandemic preparedness and response, which I am co-chairing at the request of the WHO Director General. Sometimes you get a hospital pass, and I think this might have been one of those. Always up for a challenge. But first, let's cast our minds back to where each of us was a year ago, 1st of February 2020. Maybe many of you were here preparing for the summer school, the 24th one. A pandemic was the last thing on our minds on the 1st of February 2020. I was in Europe. I travelled there via India, where I'd been at the country's flagship geopolitical dialogue. It was shaping up to be a normal kind of year, really. I went on to the World Economic Forum in Davos, then on to Oslo, where is the headquarters of an organisation that I chair, and then to the United Kingdom. I was, of course, aware from media reporting at the beginning of January that the WHO was requesting information from China about the emergence of cases of pneumonia of unknown origin in Wuhan. The virus, of course, in the weeks after that was sequenced and identified as a novel coronavirus, known simply at the early stage as 2019 nCoV. It's not abstract, isn't it? And that's, I guess, part of the point I want to come to. That at Davos, then, I was present at what turned out to be an impromptu briefing on the 23rd of January, when news came through from Geneva that the emergency committee convened under the international health regulations for a second meeting, well, at its first meeting, had not taken a decision to declare the novel coronavirus a public health emergency of international concern, a so-called FEIC. That's a new acronym we've had to get our minds around. FEIC, Public Health Emergency of International Concern. And that is the highest level of alerts under the IHR. I was in the United Kingdom at the end of the month when the FEIC was finally declared, and the media was by then reporting extensively on the crisis in Wuhan, in the hospitals and in the lockdown. But it all seemed a bit abstract, strangely distant, with remarkably little comment on the threat which the virus could pose to the world at large. The WHO had issued a package of guidance at the time of the FEIC, including on the important role of testing and public health measures, but travel restrictions were not recommended. In mid-February, I was in Geneva for the launch of a Lancet Commission report at the WHO, and there was clearly mounting concern there that the small window of opportunity they saw to avert a pandemic was closing rather fast. Despite the declaration of the FEIC 2.5 weeks earlier, it seemed that really far too few countries had escalated their preparedness and emergency operations. On 11th of March, by which time the disease had been reported in more than 100 countries, and Italy had imposed the first nationwide lockdown in Europe, the WHO characterised the disease as a pandemic. And while that term has no legal meaning in the WHO dictionary, of course it attracts attention when used. Pandemic! We sit up, don't we? I think language is important. And it was really only then, I think, 2.5 months after the Wuhan authorities first reported cases, that much of the world seemed to begin to understand the potential implications of what was unfolding and to react accordingly. Of course, the disease was spreading exponentially then and continued to do so. The annual World Health Assembly in May had to be held as a virtual meeting. At that assembly, the member states were clearly deeply concerned by the pandemic, And through a resolution, they unanimously called on the Director General to initiate at the earliest appropriate moment and in consultation with Member States, a step-wide process of impartial, independent and comprehensive evaluation, including using existing mechanisms, as appropriate to review experience gained and lessons learned from the WHO coordinated international health response to COVID-19, including the effectiveness of the mechanisms at WHO's disposal, the functioning of the international health regulations agreed to in 2005, and the status of implementation of relevant recommendations of previous IHR review committees. To look at WHO's contribution to UN-wide efforts and the actions of WHO and its timelines pertaining to the pandemic, and then to make recommendations to improve capacity for global pandemic prevention, preparedness and response. You'll recall I talked about a hospital pass. So, in July, Dr. Tedros approached me and the former President of Liberia, Ellen Johnson Sirleaf, and he invited us to be co-chairs of the review. Well, what can you say? We agreed. And of course it has been consuming a great deal of time ever since. And as many of you will know, the world's meetings don't seem to revolve around the centrality of the New Zealand time zone to us. So sleepless nights at the order of the day. Dr. Tedros gave us full license to carry out our work independently. And let me stress, our panel is totally independent of WHO. They pay the bills through assessed contributions, but our secretariat is outside the premises. It is a fully independent review. One of the first jobs we had to do was establish a secretariat from nothing, define terms of reference which are very closely modelled on the World Health Assembly resolution, and assemble the panellists. I appointed an Auckland Medical School graduate, Dr. Sudhir Singh, as my advisor, and he was able to go down from his job in Oslo to Geneva at an early stage to help get the work underway. He's been truly indispensable. We then were able to assemble a group of 11 prominent people with very wide experience from around the world to serve on our panel. We have the former President of Mexico, Ernesto Zedillo. He was leaving the presidency as I was coming into being Prime Minister all those years ago. The former British Foreign Secretary, David Miliband, who's now CEO of the International Rescue Committee. The former Finance Minister of Colombia, Mauricio Cadenas. Former Directors General of the Health Ministries of India and South Africa, Preeti Sudan and Precious Matsoso. Precious also has a history with the WHO. The former Executive Director of the UN Population Fund, UNFPA, Thoraya Obaid. 2 former heads of the Global Fund to fight AIDS, TB and malaria, Michelle Kazatkin and Mark Dybel. Also the first person to describe human-to-human transmission of the novel coronavirus publicly, Professor Nanshan Xiong of China, who had deep experience with the SARS pandemic and is the editor of an international journal of respiratory medicine. Joanne Liu, the former president of Médecins Sans Frontières, whose term of office there coincided with the West African Ebola crisis, and the current youth envoy of the African Union, Aya Chebi. We felt it was very important to have a youth voice on the panel. We met for the first time in September, and we will have the 4th meeting next week. And we will issue a substantive report with recommendations to the World Health Assembly in May this year. The review has the formal title of the Independent Panel for Pandemic Preparedness and Response. It's a mouthful, so we often talk about the independent panel. The work has been organised around 4 themes: to learn from the management of past pandemics and look at the status of the global health system prior to COVID-19. To draw up an authoritative chronology of the unfolding of the pandemic to help understand where responses could have been improved, to assess the direct and indirect impacts of the pandemic on health systems, societies and economies, and to elaborate a vision for a strengthened international system which is better equipped for pandemic prevention, preparedness and response. I characterise our task as being to distill lessons from what has happened and make recommendations which, if they're implemented, could help avert such a catastrophe again. So it is a truth-seeking exercise, not a blame-casting exercise. The methods of work include desk reviews, interviews with stakeholders, accessing WHO's internal documents, town hall dialogues and expert symposia, briefings and meetings with member states and regional and other groupings, and coordination with other formal review bodies, and there are a number. There is another International Health Regulations Review Committee operating. There is the Independent Oversight and Advisory Committee for the World Health Organization's Emergency Program, and there is the Standing Global Pandemic Monitoring Board, which was set up in 2018 by the WHO and the World Bank. Last month, mid-January, the panel presented an interim report to the WHO Executive Board. Our report was described by the New York Times as follows. It is both a bleak recounting of deadly missteps and an early blueprint for repairs. The Times went on to say that the report describes one failure leading to another, from the slow, cumbersome and indecisive pandemic alert system to the years of preparedness plans that failed to deliver, to the disjointed and even obstructive responses of national governments, end quote. And that is actually a fair summary for us. We say that there have been failings in global and national capacities before and since the emergence of COVID-19, and that these contributed to it becoming a pandemic. There had, for example, been a wide lack of preparedness at the national level. We note that the scores which countries received in various preparedness assessments did not predict the success or otherwise of how countries handled the pandemic. And we suggest that the scoring may not have had sufficient regard to leadership and political factors which have played such an important role in responses. Let us not forget that the 2019 Global Health Security Index, not a WHO exercise but an analysis by a respected team of health security experts, placed the United States first out of 195 countries with a ranking of 83.5 out of 100. It ranked the UK second with a ranking of 77.9. Our little country, 35th with a ranking of 54. Enough said. So, there was definitely a problem with the metrics used to assess preparedness. But then it was also a problem that many previous warnings that much more needed to be done to prepare for an inevitable future potential pandemic had been dropped into a too hard basket. Our panel has been looking at the reports of no fewer than 12 previous commissions and panels which reviewed gaps in pandemic responses. And they made many worthwhile recommendations, but many were never implemented, including because member state agreement could not be reached, and also perhaps because there just wasn't a big enough vision for the scale of reform required across the international system. The gaps which those previous reports and recommendations pointed to included that countries were not taking seriously enough their responsibilities to have in place the core public health capacities to prevent a pandemic, that there was no mechanism for states to work together, either in support of each other or to cajole each other into action, and that there was no obvious pool of resourcing, be it financial, in the health workforce or supplies, to draw from should a global crisis hit. The panel is shedding light on the consequences of all these shortcomings by looking in meticulous detail at how the pandemic unfolded. The development of the authoritative chronology of the emergence of the novel coronavirus is a critical part of our work, because from that we can discern where the critical gaps existed and the time delays occurred. And we are synthesising the extent of the spread of the virus around the world with the pace at which evidence was generated, when recommendations were issued, and when responses did or didn't take place. So we consider that the chronology will speak for itself. There are clearly things which needed to have been done faster. That needed the full cooperation of member states carrying out all their responsibilities under the international health regulations, and it needed the World Health Organization, which is empowered to act. Our panel's impression is that the WHO is simply underpowered and underfunded to do the job the world expects of it. It has no rights of access to expect when and where there is a disease outbreak. And the international health regulations have few enforcement powers associated with them. The WHO, therefore, seems unduly constrained by the regulatory and other regimes which member states have approved. We think it should be able to act in a precautionary manner. That is, it ought to be able to act swiftly and on the basis of a worst-case scenario, even in the face of uncertain facts and uncertain science, which will always be the case when dealing with a newly emerging disease. A month went by from when Wuhan, on the 31st of January, issued a public bulletin about the cluster of cases of pneumonia of unknown origin, to when the WHO's emergency committee supported at its second meeting to support the declaration for public health emergency of international concern. That was a month when case numbers were expanding in China and beyond its borders. This was not like 2003 and SARS, when air travel within and beyond China was a fraction of what it is today. This was 2020, with a highly globally connected world. In these circumstances, frankly, hours and days matter in curbing transmission of an infectious pathogen, and a precautionary approach by WHO is warranted. As well, the cautious approach in the international health regulations towards measures restricting travel seems unrealistic in today's circumstances. What has been surprising to the panel is to explore the relatively lacklustre response which there was at country level globally in the month of February. February is like a black hole, particularly outside the East Asian region. To use an Antipodean phrase, much of the world seemed to stand by like a stunned mullet. The declaration of a public health emergency of international concern is something to be taken very seriously. Put simply, there was a disease to be contained. Collectively, the world failed to do that. Our panel has observed that the geopolitical tensions of 2020 were certainly not conducive to management of the pandemic. And the contrasts with Ebola in 2014 are very stark. Of course, the WHO was very slow and greatly criticised in its reaction to Ebola. But when eventually full global attention went on it, the UN Security Council actually resolved to declare Ebola a threat to global peace and security, and to urge member states to do whatever they could to overcome that threat. No such resolution has been agreed by the Security Council this year. It did belatedly reach agreement on supporting the Secretary-General's call for parties to conflicts to cease hostilities in order to fight the pandemic. That call and that resolution appear to have fallen on deaf ears if the raging conflict in rather a number of countries is any guide. The pandemic, as we all know, has had profound economic and social consequences. Many health systems have lacked the resilience and business continuity models to deliver essential services. Much of the world's health workforce is very stressed. Children and young people all over the world have missed out on education. Domestic violence has soared. Jobs and livelihoods have disappeared. And whole economies and government revenues have suffered. Let's look at the contrast with 2007-9 and the global financial crisis, which had profound social and economic spillover effects. At that time, the G20, representing 85% of the world's economy, rallied huge resources for the international financial institutions to support countries in difficulty. There has not been a commensurate effort during this crisis, meaning that many countries will emerge from it in worse shape than they could have. And this too is a byproduct of global tensions and the ability to agree on nothing much. One of the basic obstacles to sound responses to the pandemic was an early assumption from a number of voices that there was a trade-off to be made between economies and people's health. The calculation those voices urged was, in effect, to take the risk that COVID wouldn't be too serious, put public health advice aside, and do everything possible to keep economies going. Well, it would be an understatement to say that that turned out to be a major miscalculation. Turning health and the economy into diametrical opposites not only defies common sense, after all, what use is wealth without health, but also it has turned out to be a very bad way to try to manage the pandemic. While economists are still poring over the data about the relationships between public health measures and economic performance, and the pandemic is far from over, nonetheless, the picture which is emerging is that tackling economic vulnerability goes hand in hand with tackling pandemic vulnerability and not tolerating transmission of the virus. Countries without social safety nets and/or with large sectors of the population in informal employment and/or living in poverty have found it much harder to implement public health responses. Across all steps, from testing and physical distancing to making sure infected people and their contacts can safely isolate at home. As well, to put it bluntly, lockdowns in the absence of social protection mean that food can't go on the table. Then government effectiveness, how quickly a support measure could reach those most in need, or even whether it is known who those most in need are, is a huge determinant of success to pandemic response. Not all governments are effective. Around the world, the pandemic then has made the inequality gradient steeper. The latest estimate from the Centre for Disease Control in the United States shows that their Indigenous, African American and Hispanic populations are hospitalised from COVID-19 at 4 times the rate of white non-Hispanic populations, and the death rate is almost 3 times higher. I remember seeing a chilling line of figures from Chicago at a certain point in the pandemic, where for a population which had 30% African American citizens, 50% of the cases were African American and 70% of the deaths. that speaks hugely to structural inequality. But the same pattern, of course, is repeated in many high-income countries generally. For lower-income countries, the impact on non-COVID-19 health services and their capacities to secure essential supplies such as oxygen has been significantly worse than for the richer countries. The panel concludes then from its work to date that there have to be fundamental and systemic changes around the prevention of, preparation for and responses to pandemics. And our May report will make recommendations to that effect. The global pandemic alert system is not fit for purpose. It is not delivering at the speed required. Financing of global preparedness and response must be seen as a global public good and invested in accordingly. Global institutions need to be empowered and adequately funded, and there need to be better coordination mechanisms across the international system. This pandemic, therefore, must be to global health what Chernobyl was to the international system governing nuclear materials and safety. After Chernobyl in 1986, countries agreed to share information and experiences as never before, and the International Atomic Energy Agency's nuclear safety mandate and its safety standards were strengthened. A new convention on nuclear safety and an internationally coordinated response system centred on the IAEA's Incident and Emergency Centre was put in place. This tells us that when the world faces an existential threat to health and safety, it is capable of acting. It is to be hoped that member state governments won't let the world's peoples down now by refusing to step up on pandemic preparedness and response. The stakes are too high, and of course those who don't learn the lessons of history are doomed to repeat them over and over again. In our interim report last month, we did call for immediate action in two respects. We said that the public health measures which can curb the pandemic need to be rolled out comprehensively and consistently. Many lives continue to be lost, approximately 15,000 each day globally last week, and many more are suffering long-term health damage while efforts to contain the disease are suboptimal. Further, these measures will need to continue as vaccines are rolled out, and one suspects that there will be an ongoing need for a number of them beyond the rollout of vaccines as new variants take hold and the disease moves from pandemic to endemic. It's critical that populations are sensitised to that. Secondly, the panel is simply appalled at what is shaping up to be a highly inequitable access to the vaccines against COVID-19. This is just one of the ways in which the pandemic has highlighted inequalities and inequities within and between countries. One would have hoped that the response to the pandemic could have had an equity focus, but no. To illustrate this, of the over 90 million doses of vaccine administered around the world thus far, I'm advised that just 55 out of all those millions have been administered in sub-Saharan Africa. And all of those are in one country, which was Guinea. The panel says that a world where the wealthy have access to coverage and the poor don't is a world on the wrong footing. Wrong because it's unjust, and wrong because it thwarts pandemic control. For even if some countries are fully vaccinated, they are still at risk if the pandemic continues to hold sway elsewhere, particularly with the emergence of new variants which have the potential to challenge the protection offered by the first batch of vaccines. So it's imperative that vulnerable groups in all countries are protected quickly and that we can move to a more equitable rollout. We have to endeavour to avoid a situation where entire populations in a select few countries are fully vaccinated while other countries are still waiting for their first dose. Over the next 3 months, our panel will continue to consolidate the evidence base it has, distill the lessons to be learned from what has worked and what hasn't, and debate the recommendations we will make. We have been urged to be bold, and I believe we will be. We're also determined that the recommendations should be actionable. Mere exhortations for more leadership and cooperation won't do, desirable as it would be to see rather more of it. A new global framework is needed, with strengthened institutions, fit-for-purpose legal instruments, adequate financing, and recognition of the importance of public health institutions and measured. What is also needed is member state agreement that a reset is required, and for the multilateral instinct, which should kick in when there's a common threat, to come to the fore. Our panel will make recommendations in good faith, backed by evidence, in the hope that change will follow.